Good day. I am Dr. Jenny Limquiaco, and I will be talking about cirrhosis and its complications. Now, we all know that liver cirrhosis is a final pathway for a wide variety of chronic liver disease. It is a pathogenic entity defined as a diffuse hepatic fibrosis with replacement of normal liver architecture by nodules. Now, this is one of the leading cause of mortality in the country and particularly affecting persons in most productive years of their lives. So the objectives of this study are to summarize the complications of advanced liver cirrhosis, and that includes acute variceal hemorrhage, ascites, spontaneous bacterial peritonitis, encephalopathy, and nutrition in patients with chronic liver disease. So first are esophageal and gastric viruses. So esophageal and gastric viruses are described as serpentine venous channels that communicate via perforating veins with paraesophageal collateral circulation. So we have esophageal viruses, which has the greatest predominance at 2 to 3 cm above the gastroesophageal junction, while the gastric viruses are in continuity of esophageal virus and or acid-free stranding gastric viruses. Now, the gastric fundal viruses in the absence of esophageal viruses should raise the suspicion of a splenic vein thrombosis. So how do you diagnose viruses? First, you can go by clinical signs and symptoms, like patient presenting with massive GI bleeding, and the second one is by endoscopic evaluation. Now, on endoscopy, you will see some stigmata of recent bleeding, which is exemplified by either a non-pulsatile spurt of active bleeding, venous oozing, or a clot that is adherent to the varix. Or you can also do imaging study, like that of the Doppler scan. With that, you will have indirect things like hepatic echogenicity, splenomegaly, dilated portal veins, thrombotic occlusion of cavernous transformation, or even gallbladder wall thickening. Another imaging study or modality is either by CT scan, MRI, or MR angiography. The other way of knowing is by pressure measurement, but this is rarely indicated. So how do you do variceal banding? Now, in upper endoscopy, the active bleeding varix should be ligated. Ligation initially should be or immediately below the site of bleeding on the varix. Now, other larger viruses should also be banded on the same session. Now, these should be carried out beginning with viruses at the GE junction and proceeding proximally at intervals of 2 to 3 cm in a spiral manner. And bleeding in this case can be controlled in up to 85% to 90% of patients in combination of pharmacologic and endoscopic treatment. Now, how do you do or manage gastric viruses? Endoscopic therapy for gastric viruses is by endoscopic sclerotherapy. So it is via intravaricial injection or paravaricial injection. So we have a lot of sclerosants, but the most common will be with the use of N-butyl 2-cyanoacrylate. Now, after initial injection, you should follow it up ideally for 2 to 3 days, weekly, bi-weekly manner, and you do surveillance 1 to 3 months or 6 months interval. But we have to understand that there are a lot of complications also, like chest pain, temporary dysphagia, fever, esophageal ulcers, and stricture. And we also need to pay attention, like presence of bacterial peritonitis, brain abscess, spinal cord paralysis, pericarditis, although these are not actually that common. So, what are the other pharmacologic management of variceal bleeding? So we have to make use of a diuretic, sympatholytic, vasoconstrictor, vasodilator, or medication that will include or increase the LES tone by prokinetic agent. So we have a lot of examples here, like diuretics with the use of aldosterone and furosemide, sympatholytic like beta blockers, vasoconstrictor like vasopressin, somatostatin or octreotide, or vasodilator like that of nitroglycerin or nitrates or clonidine, or the serotonin 5 H2 receptor. Now, how do you manage acute variceal hemorrhage? First is by resuscitation. So you need to establish IV access and fluid resuscitation. You need to secure the airway, intubate early, especially if the patient is already at stage 4 hepatic encephalopathy. And you also avoid vigorous resuscitation or overtransfusion, like hemoglobin more or less set at around 8 grams per deciliter. Because if you do massive resuscitation of all the blood loss, there will be higher portal pressure than baseline and producing more rebleeding and more mortality. So other therapy will be pharmacologic therapy with the use of vasopressin, terlipressin, octreotide. Well, this will actually cause splanchnic arterial vasoconstriction, and the somatostatin will induce splanchnic vasoconstriction selectively. So other modality are balloon tamponade, endoscopic therapy, TIPS, or surgical shunt. Now, how do you prevent recurrent hemorrhage? Now, you have pharmacologic therapy with the use of beta blocker, endoscopic therapy like varicose ligation, which is more effective than that of sclerotherapy because the mean number of treatment needed to achieve varicose eradication is much lower than that of sclerotherapy. And TIPS can also be done with an overall varicose rebleeding rate of 19% compared to 47% in patients undergoing endoscopic therapy. So next, let's move on and talk about ascites and spontaneous bacterial peritonitis. Now, we all know that patients with portal hypertension has an increased nitric oxide. With that, there will be vasodilatation, producing renal sodium retention, and there will be overfilling of intravascular volume, producing ascites formation. If there is ascites formation, there will be increased sympathetic nervous activity, increased renin and aldosterone, and the vicious cycle continues. So how do you diagnose spontaneous bacterial peritonitis? Very importantly, you need to establish serum acidic albumin gradient, or the SAAG. Now, this is based on oncotic hydrostatic pressure. Now, portal hypertension results in abnormally high hydrostatic pressure gradient between portal bed and acidic fluid. So this is computed as acidic albumin minus that of serum albumin. So if you have a SAAG of more than or equal to 1.1 grams per deciliter, it means to say that patient has portal hypertension. And what are the disease entity? Patients with liver cirrhosis, alcoholic hepatitis, now non-hepatic causes like cardiac ascites, mixed ascites, fulminant hepatic failure, portal vein thrombosis, or those patients with mixed edema or veno-occlusive disease, to mention some. And those disease entity with lower gradient are the ones that are written on the right side. So diagnosis, single most important test is with the use of acidic fluid testing, like cell count. Now, upper limit of normal for the absolute PMN is less than 250 per cubic millimeter. Now, total count of the WBC and absolute PMN are actually elevated in spontaneous bacterial peritonitis. So we have two bacterial peritonitis. One is spontaneous and the other one is secondary. So how do you differentiate one from the other? They both have positive acidic fluid culture. They also have increase in their PMN count. But for secondary bacterial peritonitis, there is an intra-abdominal surgically treatable source of infection. Treatment of acidic fluid infections. So treatment of choice for suspected SBP is cefotaxime or third-generation cephalosporin. And ideally, you need to repeat paracentesis after 48 hours of therapy. Other forms of treatment will be ofloxacin, ciprofloxacin, or amoxicillin or clavulanic acid, with a duration of 10 to 14 days. Next is hepatic encephalopathy. There are several stages of hepatic encephalopathy, ranging from stage 1, which is exemplified by just a decrease in attention span, changes in personality, irritability or impaired computation or construction skills. If you have stage 2 hepatic encephalopathy, there will be appearance of movement disorders and asterexis. For stage 3, increased obtundation, and the patient is still arousable. But if your patient is already at stage 4, they are already comatose, and they reflect severe bilateral cortical dysfunction or involvement of brainstem. And there is hyperreflection, muscle rigidity become more apparent. So what are the common factors that will precipitate hepatic encephalopathy? It is divided into nitrogenous and that of non-nitrogenous encephalopathy. So presence of uremia, azothymia, GI bleeding, dehydration, metabolic acidoalkalosis, hypokalemia, constipation, excessive dietary protein, or infection can cause or precipitate hepatic encephalopathy. Now, management. First and foremost, you need to identify and correct the precipitating factors. Assess the volume status, vital signs of your patient, evaluate whether or not he or she has GI bleeding, eliminate presence of sedatives, tranquilizers, or use of those drugs. And you also need to test for hypoxia, hypokalemia, hypoglycemia, anemia, and correct accordingly. So, institute or initiate ammonia lowering therapy. You insert NGT, give lactulose and other cathartics. The use of the lactulose is actually to acidify the content of your colon, and it favors the trapping of ammonium ion in the lumen, thus preventing absorption. And the treatment with lactulose should be able to produce around 2 to 4 bm per day. So other form of management is to decrease the dietary protein to around 60 grams per day. You can also give oral non-absorbable antibiotics to decrease bacterial counts. And use of benzodiazepine can also be done. And you also minimize potential complications, secondary infection of cirrhosis, and depressed consciousness. So supportive care is very important. Last is about malnutrition in patients with chronic liver disease. So what are the causes of malnutrition? There are quite a lot. So it's either inadequate or poor quality oral intake, maldigestion, malabsorption, or increase in energy expenditure and altered substrate demand. Now, the measurement of malnutrition in patients with liver disease is actually tricky because most of them present with ascites. With that, there are a lot of ways in order to assess the malnutrition in this set of patients. So we can make use of a mid-upper arm muscle circumference, and it is little affected by salt and water retention, and the other one is with the use of a hand grip strength. So general principle, the daily energy intake should be around 35 to 40 kilocalories per kilo, ideal body weight, and it should be within 1.2 to 1.5 grams per kilo per day. So you also encourage small meals, liquid nutritional supplement, and also emphasize the need of a late night snack. Now, other or oral branch chain amino acid supplementation may also allow recommended nitrogen intake to be achieved and maintained in patients that is intolerant of dietary protein. So the importance actually of giving a late evening snack is very important because there is a study on that it is favorable, a nutritional intervention for liver cirrhosis because it repairs hypercatabolism. It also improves nutritional state such as that of nitrogen balance and the serum albumin level. So nutritional requirements in liver cirrhosis, enteral nutrition is preferred over parenteral nutrition. Because in PN, liver function can worsen. Patients with ascites may not be able to tolerate large volume associated with parenteral nutrition. And there will also be excess dextrose and glucose, which may lead to steatosis. And additionally, long-term parenteral nutrition can also develop steatosis, cholestasis, or even the development of further cirrhosis. And there is also an increased risk of catheter-related infection secondary to immune dysfunction and increased intestinal permeability. So the lack of liver glycogen store can also lead to hypoglycemia when the patients are rapidly tapered off from the parenteral nutrition. And we also need to emphasize that an early post-operative enteral nutrition is important because this has actually shown to reduce the length of ICU stay. So that's all, and thank you very much.